You never know. You never know. I'm back in plenary session. I'm joined via Zoom by Dr. Tom Baer. Tom Baer is Deputy Cancer Director at the Knight Cancer Institute at OHSU. My old boss, Tom Baer. It's a pleasure to see you again. How are you?
It's so nice to see you. How's it going?
It's going well. I'm here in San Francisco. The weather is nice. How are things there in Oregon?
Today it's much nicer than it's been. Things are looking up. And since we're talking about COVID, we're fortunate to see cases coming down, vaccines going up. So I think we're beginning to be cautiously and preliminarily hopeful.
That's good. I'm glad to hear that, and that's my assessment too. So I wonder if we'll jump in. Let's talk about this vaccine and how we advise people after the vaccine. You're a cancer doctor. I'm a cancer doctor. We sometimes are in this game. We have patients who are immunosuppressed and they're looking for advice about what they can do, what's safe. How do you think about this? How do you think about this question?
Well, first, let me just say a couple things in opening. I mean, I think it's important to acknowledge that I'm not a virologist. I'm not a vaccinologist, and I'm not an expert in public health. Like you, I'm a physician who's trained to read the literature and think critically. And so that's what I bring to the table to this discussion. But I would like to fully acknowledge that I'm not a world's expert in viruses.
Well, Tom, that never stops anybody. Don't let that stop you.
And secondly, whatever fun comments we're going to share, I do want to start with saying that it's just remarkable to see the development and deployment of these vaccines, and for all the controversies along the way and the challenges and the disputes about who goes first and so forth. The fact that we're even able to have this discussion at this point in time, just about a year after the pandemic really hit the United States in earnest, that's just incredible. And I think the folks that were responsible for the development of these vaccines, we ought to be having ticker tape parades.
Yeah, absolutely.
Folks and be building monuments to them, and they should be the superstars, and perhaps not some of the other folks that we put up on a pedestal now.
I agree with you wholeheartedly. If you asked me last March, would I predict they'd have a vaccine by December and a vaccine this good? I would have said no on both counts. So I was blown away. I'm super impressed. Hats off. Amazing achievement of science.
Yeah. No, I think, it's an interesting time, and it's interesting to think about the implications of the vaccine for what we can do. I haven't had a chance to read the latest CDC guidelines that just came out. I'm sure you're going to bring me up to date on those. But, the thing that I've been struck by is that there's been so much caution about the unknowns around the implications of the vaccine for transmission. And I think there's some things missing in that conversation. I mean, I've heard my friends who are not in the medical field say, well, the vaccine doesn't stop transmission. That's what they're hearing in the public health message, which is almost certainly completely wrong. I mean,
I know.
It's hard for the general public to understand the distinction between we're not sure yet, we haven't measured that endpoint, and we don't know how much the vaccine reduces transmission. It almost certainly does. We just don't know maybe how much, versus it doesn't reduce transmission, which is what I think a lot of the members of the public are hearing. And the other thing that's missing, I think, in that conversation is that, we speak about herd immunity, which, by the way, I don't really like the term herd immunity. We're not really, if we were a herd, we'd all be behaving in an organized fashion. Humans are hardly a herd. I think hardly. Maybe community immunity is a better term. But in any event, we talk about that concept at the same time as we talk about the idea that we're not sure how much the vaccine reduces transmission. And of course, those two positions are incompatible. You can't have herd immunity if the vaccine doesn't reduce transmission, right? So it's completely inconsistent with one another.
Hypocritical. Yeah, those two statements. No, I agree with you 100%. I don't know if you follow along, but in January, the end of January, I wrote an op-ed basically arguing that, the vaccines will and substantively reduce transmission. And we had already had the data there. We had swabs on dose 2 Moderna showing a 60% reduction in PCR positivity. We have data from the polyclonal antibodies that they reduce that antibody titers in the blood will reduce the amount of nasal carriage of the virus.
Yeah.
And we have the experience of pretty much every other vaccine ever made, all but one, to my knowledge, that also slows transmission dramatically. And we know transmission to some degree is driven by symptomatic people, and this will lower that. So we know it's going to do it. Yet, there was reluctance. I wrote my thing saying that, after vaccination, you can hug your grandma, you can have dinner parties. I got some pushback, a lot of pushback. You're familiar with this. A lot of people tweeting at the employer and said, "Why does this guy work there?" This time it doesn't go to your desk. This time it doesn't go to your desk, Tom. Yeah, and
well, I would say that I'm not going to hold myself out as an expert on what we can and can't do. Sure. I mean, I don't think that would be responsible of me. But I would point out that I think some of these, I would say, caution biased communications may do a disservice to the acceptance of the vaccine. I mean, if you think about it, what the customer wants, the customer being the American people, right, is they want to be safe themselves. They want to keep their loved ones safe, and they want this bloody thing to be over so they can travel, go out to dinner, and get back to a normal life. So if your job is to convince the public that there's this great thing that's going to help end the pandemic, and that's the vaccine, and you say, well, it's going to make you safer, but it's not going to make your family any safer, or at least we don't know, and the public hears the latter. And you can't really change anything that you're doing. You still have to maintain all the restrictions. I mean, I think that is not a great sales pitch for the vaccine.
No, that's not great. That's terrible.
I'm not saying we should be selling in the cheap sense of the term. I mean, we should be selling in the good sense of the term, which is letting folks know that this is really a compelling thing to do. And that, yes, we don't yet know how quickly and how completely it will reduce transmission. We haven't done the experiments on hugging your grandparents, but the data are pretty darn good, and you probably can, especially obviously if your grandparents are also vaccinated. And in any event, it's just such an exciting thing to avail ourselves to get us closer and closer to back to normal. And we're kind of missing that opportunity with the really caution-focused messaging. And I'm not suggesting that we should throw caution to the wind. And I completely agree that we're in this critical moment where there are concerning variants. We've not yet vaccinated the majority of our population. We don't want to do dumb things. So I don't disagree with that message, but I would couple it with perhaps a little bit more hope for what this vaccine is going to realistically achieve for people pretty soon.
Yeah, no, I agree with you. And I think that's just that's just the truth about the vaccine. And today the CDC guidance reflects that. I mean, it does say that, if you're vaccinated, you can have small get-togethers. It does support these things that, people have been talking about for a few weeks. But I think you're putting your nail on the head, which is this, the word you used was sort of a caution-centered narrative. That caution-centered narrative group, that's a strong coalition that is caution sensitive. And I think they're a little bit caution sensitive, maybe because of some of the missteps early in the pandemic, where I remember, in January and February of last year, the media telling me over and over again, you should worry about flu more than SARS-CoV-2 because flu has killed more people this season. Of course, that was backwards. I should have worried more about SARS-CoV-2. I wonder, from your point of view, you're a physician. You've been in science for a while. We shouldn't decades, but let's not say how many. I don't know. How do you think about the scientific dialogue? I mean, to one degree, it's different. We've used to be able to meet face to face. Now we're doing it by Zoom. When you go and look at the landscape, when you see what people are talking about, how do you think the scientific dialogue is going?
it's hard for me to assess all of the scientific dialogue, and I don't know if you're talking about the scientific dialogue on Twitter, which I'm generally not a part of,
Good. You're a wise man.
or in the literature. But I do think that a lot of the dialogue, including some of the scientific dialogue, has become a little too divided into camps, and some of the sort of oriented towards identifying evidence in support of one's position rather than an open outlook on wherever the data take us. And it's a little frustrating to see that. And I wouldn't want to indict certainly the entire scientific community and all journalists and things like that. I think there's plenty of really solid dialogue out there. But I don't know whether it's been the political angle on this that developed over the past year that's made it so difficult to have sometimes a conversation about the issues that departs from kind of one channel or the other. For example, I'm eternally puzzled by the fact that face masks are in the same bucket as business closures and school closures, in the sense that the right generally opposes them and the left generally supports them. And in my mind, closing schools and closing small businesses has a really substantial cost to it. And we can have a great conversation, maybe not you and I, because I'm not an expert at that, but as a society, how you balance those costs and benefits. But face masks, I mean, they are just all upside. They're a fashion expression opportunity. They're a little inconvenient and a little uncomfortable, but I would think that anybody who wants businesses and schools open would be a big fan of face masks and anything else at all that can reduce the transmission of the virus. Wearing face masks does not put people out of work and put people in a position not to be able to pay their rent. And why are those things lumped together? I don't understand.
No, it's a great, I mean,
yeah.
It's a great example. And to be honest, someday there's somebody who I'm going to bring on this podcast and I want to ask this question to, which is the question you're pointing out, which is that, hypothetically, if you are somebody who is critical of business closures and lockdowns, and there are many such people, and they have good arguments, I think, which is that there's serious downsides to this intervention, and who knows what the potential upside is. But if you're such a person, and we know they tend to fall on the political right, my question to those people has always been, why don't you embrace masks, even if you don't think they do that much? Because it will allow you to open your business, which it sounds to me like is the priority. So I've never had a good idea why, you're putting your finger on the right spot. I've never had a good idea why those two are wedded. I would think, even if in your heart of hearts, some of these people don't think it does that much, the mask, I would think they would support it just because it allows them to get their business open. We put up with all, you and I know, in medicine, we jump through a lot of hoops to be able to run our clinic, a lot of bureaucratic hoops. We may not agree with all the hoops, but we jump through them so we can do what we think is most important, which is running our clinic. And I would see it the same way. I agree with you. I don't understand why they became wedded.
Yeah, it's almost I don't think it's a scientific alliance,
Cultural.
but it's also, if we're going to stir up controversy and say things. The other thing that I wanted to talk to you about a little bit is what I see as a relative lack of curiosity about what we see all around us on behalf of the media that informs us. I mean, I just read a wonderful piece in the New Yorker about how COVID has affected the world very differently. I don't know if you saw that piece, where, surprisingly, in places like India and Africa, the mortality impact just didn't happen, which is exactly the opposite of what you'd expect. These are places where folks live in multi-generational households. They're crowded. Healthcare systems are inadequate, sometimes not up to the task. Not that ours is,
Right.
fantastic, but still, no. And yet the number of deaths per population just is incomparably lower than in the Western states, and it can't be explained by what happened, say, in China and Korea, potentially a very aggressive, effective public health intervention early on when the burden of virus was really low. That's not what happened in those places around the world. That's a fascinating story that the media isn't really tackling very well. And I think there's got to be some things to learn. When I was in medical school, one of my professors was the famous Don Coffey. You've probably everybody's heard of Don
Yeah.
Coffey,
It's Hopkins.
and he one of his sayings is that the essence of inquiry is to say, to observe what's around you and say, if this is true, what does that imply?
Yeah.
That's really the whole thing, and we're not doing enough of that. I think our media is sort of repeating pretty straightforward messages from a couple of sides. Do more of this, do less of that. Um, don't do this, do that. But there's not a lot of really critical look at what's going on. Why is it that that the excess mortality in California and Florida are pretty similar? I'm not going to take a position on. I have
Right.
no idea why.
Right.
Maybe the variants in California are more aggressive, and despite more aggressive government stance, they overcame that. Or maybe the folks in California didn't follow the orders as well, and so on a net basis, the intensity of interventions wasn't as different as we thought. But
Right.
I don't know. But
Right.
that's a great story that nobody's writing.
Right. And I think you're spot on. And I guess I would extend it a little bit. I mean, the way I would put it is there are these differences, and it is an open question. What are the factors for it? And I wrote something about it. I had 6 buckets, and I don't know how much you put in each bucket, but here are my 6 buckets. One is, are you measuring the thing the same? So we know that the definition of a case and the definition of hospitalization, the definition of a death, maybe there's some variability place to place. Possible. Next thing is early pandemic events. When the entire world shut down in early March, some nations may have had more seeding events than other nations. And so if you start with 10 seeding events versus 100,000 seeding events versus 10,000 seeding events, maybe there's a difference. So maybe Australia had different preconditions than the US, that moment we all shut down mid-March. The third bucket I put is the bucket that everyone wants to talk about, which is the actions of human beings, our policies, our restrictions. Maybe that made the difference. The fourth bucket, I think, has to do with the differences in the built environment, our population density, our structures, our ability to lift up the drawbridges. Like in New Zealand, they can lift them all up really quickly. The fourth bucket, I think, differences in the people, the age structure of the population, such as sub-Saharan Africa, India, a lot more young people. Maybe that has a role. And then the last bucket I always put is stochasticity and chaos, which is, there's some degree this is random, and some pandemic spread will stop on its own from a chaotic sort of pattern. And the answer is, why did Florida do this way and California this way and Taiwan this way and Canada that way? It's going to take years. And I do agree with you that it's so easy for everyone to succumb to a simple narrative, which is that, well, it's this or it's that. But the truth is, as you put it, you need to have some curiosity. And I don't know what the answer is. I bet in a few years, there'll be some really elegant research that might help us figure out what mattered and when.
I mean, I think it's human nature to want to explain things and arrive at an explanation. And it's really easy to try to do that with the things we know. And it's, so you see the outcome numbers, what the local government actions might have been. You can measure some mobility metrics and things. Those are the things we know and understand. But they, certainly when it comes to India, I don't think those known factors explain the whole thing. Even the age distribution doesn't appear to be a full explanation, at least as if you believe what was written in the New Yorker.
Right. I
Uh,
agree.
I know, I think some of the hypotheses have to do with potentially unrecognized pre-existing immunity due to
Right.
exposure to some other related or similar viruses in the past, or perhaps some other unknown uh, factors. But
Right.
the differences are big. These
Yeah.
aren't subtle differences.
Right. It's massive. Yeah.
And the issues with the reporting, I completely agree that those are real issues. But if you look at, for example, total mortality by age group or in total, and look at what people are referring to as excess mortality, where you compare the deaths occurring this year across your whole population, or maybe across various age groups, to the last 5 years in a row, and sort of the expected curve. I mean, you can see that data in the New York Times every day. Um, and you, and that integrates everything. It integrates COVID deaths, non-COVID deaths that may have been decreased or increased as a result of our, response to COVID. I mean, there's a complexity to that as well. I mean, I'm sure I've been getting a refund on my auto insurance ever since COVID started, which tells you right away that there's very likely fewer car accidents
Right.
because
Right.
you haven't been driving. So there's all these secondary factors that drive into that, but ultimately excess death calculations, give you the full picture, and it's hard to hide behind reporting biases in
Right.
the kinds of
No,
stuff.
that's fair. Yeah. No, I agree with you there. Um, my question for you, you're somebody who you've come on this podcast before to talk about business matters. You're business savvy. Um, so as a business person, I wonder if you might talk a little bit about the downsides of some of these interventions, and whether or not you think they'll translate into simply economic downside, or is there a downside to health from prolonged closure, from shutdowns, things like that. Um, are there things that you think about there?
Well, I think that's where you get into some topics that are very passionately held by a lot of folks. And
Yeah.
I mean, it goes without saying that any um, any action has consequences, right? And those consequences are desired and undesired. I mean, that's true of an antibiotic prescription.
Uh-huh.
Anything we do, right, has that. So it's pretty obvious that if you um, take actions that close businesses or close schools in particular, there's going to be folks out of work, folks struggling economically, kids falling behind. And the problem, though, is that most of the time when we get into these debates about which is worse and whatnot, um, it's really hard to measure what you're really after. So, for example, the folks who want to take a side will measure the current state and measure it against their perceived harm.
Mhm.
But of course, if you don't, if you don't take some measure, I mean, I don't know how effective the measures are, but let's assume that the measures are effective at some level. If you loosen them, then you get more infections. So your comparison isn't really, you know,
Yes.
it's a dynamic system. So it's
Yes.
hard to weigh it. And I don't envy those public health officials who are trying to make those decisions. I'm not going to, get on here and bash anybody, because they're really tough decisions. But there's no question that there are significant downsides. And unfortunately, as you know, and as many have said, those downsides tend to accumulate uh, to the most vulnerable in our society. And that's on both sides of the ledger.
Right.
That's on the infection side and consequences of COVID. And that's also on the economic consequences. And I think it's really amplified that. And we see it all around us, where those of us who are able to work remotely, are invested in the stock market, I mean, have probably are no worse off, except,
Right.
maybe you haven't seen our family and friends as much, and
Right.
it's been hard. Whereas the folks on the front lines, may have, in the restaurant industry and the travel industry, they've been really, really injured by this crisis. And I think we have a responsibility as a society to help get them through this. So I'm glad to see that the current relief bill, for example, has some help for restaurants. I mean, that's
Right.
like one of the hardest hit sectors, and
Right.
they weren't included
Right.
in the prior help. We helped the airlines, which is important. But airlines are big, and if they fail, that is really visible. Restaurants are often small, but they are businesses that feed families for generations.
Yeah.
And I'm glad they're getting some help.
Yeah, and that's well put. I know you have a hard stop, so our time's almost up. But I wanted to ask you something before I got you. Olaparib prostate cancer. You've got your approval. Okay, here's my question for you. You're a prostate cancer expert. I can't let you off the hook. Do you give? Do you? I suspect you use it in the right patients, but my question is, who are those right patients for you? Do you use it pre-taxane or only post-taxane? Do you use it in BRCA1, BRCA2? Do you use it in ATM? Which mutations are the ones you consider it in? How are you using olaparib and rucaparib?
Well, I know this is your favorite topic, and I'm sure you felt vindicated by the NICE decision.
I did follow. I did follow.
So, and I think that it's a wonderful question that you ask which patients to use it in, because that I think gets a bit lost in the debate. And it's pretty clear from the data so far that number one, we don't know enough, because for many of the mutations we're talking about, there's literally still just a handful of patients.
Right.
But number two, for those mutations where you see a 5-10% response rate, my answer to that is, I could use oral Cytoxan or oral etoposide, which is what we used for prostate cancer before we had mitoxantrone, the exciting new drug that it is. And that produces a 10% response rate in unselected patients. Carboplatin alone has a 20+% response rate. There are 4 phase 2 studies of single agent carboplatin in prostate cancer that nobody has read in 25 years.
Yeah.
So to use a targeted drug in a targeted population and get a 10% response rate, that to me is unsatisfying. I think that the data for BRCA2 are really quite good. And there, I still think we have a lot to learn about, biallelic loss, which ones are really the right ones. But in particular, patients who are carriers of BRCA2 mutation to begin with and very likely have a second hit, those folks I think are good candidates. I don't recommend it in ATM patients, despite the fact that that was included.
Right.
The olaparib label. I was disappointed to see that. It was a lumping that was rational to begin with, but the data are the data. And I think the purist might even say that BRCA1, there's just not that many cases, and that the case is not as compelling. There may be other mutations that emerge, RAD51, PALB2, but the numbers are so small, it's hard to know. So, I think there's a place for these agents, despite your views about them. But I think, we want to maximize the benefit and minimize the cost and side effects and whatnot. So patient selection is key to a practice with PARP inhibitors.
That's fair. So I guess the only thing I would say is that everything you said tells me that what you're talking about is after docetaxel. I mean, you're talking about the post-taxane setting, dosi and cabazi.
I think, well, as you know, for your audience, rucaparib was registered after a taxane. Olaparib was not.
Right.
Taxane was not required.
Yeah.
I think that ends up being a very human and individual choice. I mean, it's not too difficult to have a spirited debate that's a lot of fun based on the data. But I do want to say it's a little different when you're dealing with an individual human being who brings values and priorities to the table and who may have strongly held preferences as to how they would like to approach the care for their cancer. And so I wouldn't say I'm dogmatic about it. I think most of the time it's after a taxane, but there may be an occasional circumstance where I'm particularly encouraged by the mutational profile. I'm convinced that there's functional loss of BRCA2. I'm dealing with a patient who is anxious about chemotherapy. I'm
Sure.
not going to take a Vinay Prasad data-driven stance and say, no way. You know,
Well, to be
I'm going to
perfectly
apply
honest,
some human judgment to the
if
problem.
I'm in that situation, the reality is I will bend my stance. But I guess my stance has more to do with how they ought to be approving than what individuals ought to do. Because the truth about bedside medicine is you always end up doing what you think is right in that situation.
Yeah,
Yeah.
there's still an art to medicine, to be
Yes,
sure.
of course, always, always. And so even approvals that I have railed against, you may find, in fact, that sometimes I prescribe the product. But that's the difference, I think, between where we want the sort of gatekeeping to occur.
So I have
But
a
yeah,
question. Can I ask you one last COVID
yes,
question?
it's your time that's about to run out. I've
All
heard.
right,
Okay,
yeah,
okay,
well,
tell
I'll be
me.
2 minutes late to my next meeting.
Okay,
So
good.
herd immunity.
Yes,
So I was interested in seeing that, the CDC estimate for how many actual COVID cases have been in the United States
yes,
back in September was 7.2 times the reported cases. The most recent update is 4.6
yes,
times. If you multiply 29 million by 4.6, you get to about 130 million infections. First dose vaccines have been delivered to somewhere, I don't know, 50 to 60 million people.
yeah. I
It's
think 19%, 20%. Yeah, yeah.
yeah. So, what do you think? I mean, are you
You.
willing to make a prediction as to when this thing is really going to start turning? I don't think it's a black and white
Yeah.
herd immunity at 80%. I think it's a process where, as more people are immune, there's going to be, the R naught declines and
Yes.
the pandemic begins to subside. So what do you think?
Okay, I guess my 2 cents are I agree with your premise. Herd immunity is not a fixed value, it is a moving target based on population admixture and things of that nature. So if you have a population that's mixing quite freely, you get these sort of theoretical herd immunity thresholds. But if you have a population where there's some mixing within strata and not as much cumulative mixing, the threshold varies. Herd immunity doesn't mean there'll be no cases. Of course, there will always be breakthrough cases as that equilibrium point just dips below. So I think there's a range of opinions. I think Marty Macri has his Wall Street Journal opinion article where he thinks we'll be there by April. And he's pretty confident that the cases will get very low. I think John Ioannidis, another person I've had on this podcast, he thinks that we have done a poor job of ascertainment. So I think he also thinks that we're probably getting pretty close to that. And I think Gottlieb has his article with Mark McClelland saying something similar. I guess if I had to speculate, I think by the summer, if you make me guess, and I hate to do this, but I think by the summer we'll have very low cases. I think things will feel as if we are at that steady state. I think in the winter of this next year and in the winter of the year after, I think we will likely have breakthrough COVID-19 cases. I don't think we're going to get to a COVID-0 situation, and how we deal with that will be sort of an open question. But I guess I'm optimistic that by summer we'll be in a good place,
Good.
for some of the reasons that you articulate.
All right. Well, maybe we'll leave it there. I can't top that prediction.
It's good to talk to you, Tom.
Nice to see you, Vinay.